Yes, we can see your screen.
Perfect.
And yes, I think that we're good to go. So let's start. Good evening to you all. Thank you for joining us in today's session organized by Karo Talks. Karo Talks is an initiative of the palliative care residents at La Sabana University to discuss with experts hot topics in palliative care. Today we had the support also of the geriatric department of Fundación Cardio Infantil and the Department of Family Medicine of La Sabana University. So we thank them very much for helping us to set up this session. Today we'll be talking about frailty and its outcomes on older people with cancer. For this purpose, we have invited to co-host this session, first of all, Laura Gelfman. Laura is an internal medicine and palliative care physician. She has a master in public health and works as the Deputy Director of Quality and Clinical Information for the Department of Geriatrics and Palliative Care at Mount Sinai. Good evening, Laura. How are you?
Thanks for having me.
It's our pleasure, and thank you very much for being here. I just want to say before we introduce our special guest that she recently had published two outstanding papers, one entitled Palliative Care at the End of Life Considerations for the Frail Patients, and the other one, Dose of Palliative Care Matters. Let's figure out how to measure it. I would really recommend all of you that are hearing this to go and check that out because they are amazing papers. And as you have already know, today we have our special guest, Dr. Josia Valtusen. She she is a medical doctor and a PhD student at the Medical Oncology Department of LUMC in the Netherlands, and currently her PhD project aims to improve the evidence for systemic treatment in older patients with cancer. Currently, she is doing an internship at the Geriatric Oncology Department of the Instituto Nacional de Ciencias Médicas y
Explica,
Nutrición in Mexico,
tú me
and
explicas,
learning.
¿oíste?
I think that somebody has the mic on. Please, if the people can double check to help us. Thank you very much. And right now, as I was saying, Dr. Valtusen, she is learning more about global oncology and how to speak Spanish, which she already made an outstanding demonstration. She loves hiking in nature, reading books, and cooking. And well, without further ado, please let's hear her. Thank you very much, Dr. Valtusen. The scenario is all yours.
Well, thank you so much for this beautiful introduction and the good pronunciation of my name. And I'm very honored that today I can tell you something about my article that was published a month ago in the JAMA Network Open. And this article is about the association between chemotherapy-related toxicity and quality of life and physical functioning in older adults treated with chemotherapy. And in case you want to see the article, you can also screen the QR code. Let's see if it... Well, my name is Joosje Baltussen, and I'm a medical doctor from the Netherlands, and I'm also a PhD student, and I'm currently working in the geriatric oncology group of the Leiden University Medical Center in the Netherlands. And I think this is the biggest geriatric oncology group from the Netherlands, and I'm part of this team since 2.5 years. And our group has published over 150 articles about geriatric oncology. There were and still are 22 PhD students in our group, and we've included 25,000 older adults in studies the past years. And this group is led by my supervisor and Professor Johanneke Portilje, who is a medical oncologist. But in our group, there are also other oncologists, surgeons, geriatricians, nurses, and of course, PhD students. But as Juan said before, currently I am not working in Leiden, but I'm working in Mexico City, because since July, I have been working as a visiting PhD student with Dr. Enrique Soto as my supervisor. And he is a geriatric oncologist, so he did both fellowships, and he's working in Mexico City. So I'm working in the Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán in Mexico City. And in this institute is the first and still only oncogeriatrics clinics in Mexico. And this is set up by Dr. Soto. So it's especially specialized in treating older adults with cancer. And this is why I'm learning to speak Spanish as well, but a complete presentation in Spanish for half an hour, that was a bridge too far for me, maybe in the future. So let's start with the beginning. Maybe for you this is nothing new, but the number of older adults diagnosed with cancer will continue to rise in the years to come. So for example, we know in the Netherlands that half of the patients that are diagnosed with cancer are 70 years or older. And due to our aging societies worldwide, these numbers will increase. And maybe you'll see, I know, for example, that in Mexico, we use a cutoff of 65 years or older when you're old, but in the Netherlands, we use a cutoff of 70 years or older. And although half of the patients we are treating with cancer are older adults, they are underrepresented in oncology trials. So we know, for example, that from all oncology trials, only 12% of the participants were 70 to 74 years old, and 12% was 75 years or older. So they're underrepresented. And this leads to a discrepancy because the people and we are testing our medicine are still much younger and fitter, but the actual users of these medicines are older, living with frailty and multimorbidity. And that's because, as I said before, older adults don't participate in the trials on which oncology guidelines are based. And this leads to a lack of data on the benefit and disadvantages of anti-cancer treatment, such as chemotherapy, for most older adults. And this graph might seem a bit complicated, but what it tells you is that for fit older adults, so those in the yellow bars, we do have data on the benefit and disadvantages of anti-cancer treatment. But for the patients who are pre-frail or have an average health status in the gray bars, or the frail patients in the dark blue bars, there's a lack of data on the benefit and disadvantages of anti-cancer treatment. And this is a big group of older adults. And this results in that in daily practice, oncologists have to weigh the benefits and disadvantages in older adults based on their clinical experience, for example, but not on trials or guidelines. And what's making treating older adults with chemotherapy extra complicated is that due to a reduced bone marrow function, reduced renal function, and reduced liver function, they have a higher risk of developing severe, so grade 3 to 5, chemotherapy-related toxicity compared to their younger counterparts. As you can see in this graph, older adults have a higher risk of almost all types of toxicity. So we know in older adults, when we treat them with chemotherapy, I think there's a mic on. No. Can you still hear me? Yeah. So we know that when we treat older adults with chemotherapy, approximately half of them develop severe, so grade 3 to 5, chemotherapy-related toxicity. And these toxicities lead to high rates of dose reductions, early chemotherapy discontinuation, and unplanned hospitalizations. And in literature, we often say that this also leads to a decline in quality of life and physical functioning. But I've looked into the literature and I found that in older adults, this association has not been investigated yet. So therefore, the aim of this study was to investigate the association between severe, so grade 3 to 5, chemotherapy-related toxicity and a decline in quality of life and physical functioning. Have been treated with palliative or curative and concurrent radiotherapy to screen for cognition, ADL and instrumental ADL to screen for functional status, the EQ5D and EQ+ for quality of life, the mini nutritional assessment for nutritional status, the patient health questionnaire to screen for depression, and then we had information about living situation, the past deliriums, dementia, and falls in the last 6 months. And then at 6 and 12 months after start of chemotherapy, we called these patients to ask them about quality of life and physical function. And for us, it was really important to define non-frail and frail patients. And in Leiden, in my institute, we always try to use the same definition of frailty, and maybe it's not really it's not really common frailty, but I think it's a good one. But I'm very curious about your opinion later. But what we do is that we look at the psychological domain, somatic, functional, and social domain. And for example, patients who have an impaired sick SID or dementia or history of delirium, they have an impaired psychological domain. Those patients with polypharmacy, one or more comorbidities based on the Charlson Comorbidity Index or malnutrition, have an impaired somatic domain.
¿Cómo les sirve? Por ejemplo, esto, ahorita que ellos ya vieron que esa es nuestra evaluación integral.
I think someone's mic is
A ellos, a entenderlos.
Thank you. The functional domain was impaired when a patient had a recent fall or an impaired ADL or IADL or were institutionalized. And the social domain was impaired when patients were living alone. So patients with 2, 3, or 4 impaired geriatric domains were considered frail. And because this frailty definition is not really common, we also validated our frailty index with the 10-item frailty index based on the comprehensive geriatric assessment, which is a more commonly used way to identify frailty. And then we wanted to know the association between toxicity and a decline in quality of life and physical functioning at 6 and 12 months. And we wanted to know which was a clinically relevant decline, and we used the minimal clinically important differences for this decline. And you can find the minimal clinically important difference for all questionnaires on the PowerPoint. But then we found out that unfortunately in this cohort, a lot of patients died within the first year. So of these patients, we did not have, for example, the 6 months or 12-month questionnaire. And we were struggling because if we only show the quality of life or physical functioning scores of the live patients and leave out the patients who died, the scores seem much more optimistic or better than they were in reality. So how do we have to take into account mortality? Well, that is the reason we designed a composite endpoint and looked whether patients either had a clinically relevant decline in quality of life or physical functioning, or whether patients died at 6 and 12 months. Maybe you say, well, you can't really compare clinically relevant decline in quality of life with mortality because a relevant decline in quality of life is less worse than mortality. But we know in older adults with cancer that a lot of older adults often prioritize quality of life above, for example, treatment response or even survival. So I think in this group of older adults, we can take declining quality of life and mortality in the same composite endpoint. And then something about the statistics. Well, we wanted to investigate the association between toxicity, so this is the determinant, and a declining quality of life or physical functioning or mortality, which is the outcome. And in this association, there are confounders playing a role between this association. And this is a bit more technical, but to find these confounders, you can use a DAG, a direct acyclic graph, and that can identify confounders. So a confounder is related to the association, the determinant, so toxicity, and the outcome. And based on this DAG, we identified frailty, age, treatment intent, so either palliative intent or curative intent, and hospital type as confounders in this association. And we used a multivariable logistic regression to investigate this association, in which we could correct for the confounders we identified. And because frailty is, I think, the most important confounder when we want to test this association, we stratified all results based on frailty status. So patients who are non-frail and frail. So this is the study population. We included 276 older adults treated with chemotherapy. And the median age was 74 years old. 64% were male patients. More than half of the patients had gastrointestinal tumor types. And 71% was treated with curative intent, 71% treated with polychemotherapy, and approximately half of the patients also received radiotherapy. And then what about the geriatric characteristics of this group? Well, on the right, you see the graphs of the results of the geriatric assessment. So 60% of the patients had at least one comorbidity, 60% had polypharmacia, and 60% had malnutrition or risk. Now, regarding functional status, we found that 20% were dependent on the instrumental ADL, and 80% had a recent fall in the last 6 months. And then regarding the social domain, 28% of these patients were living alone. So here you cannot see the GH score, but we found that 66% had an impaired GH score. And based on this geriatric assessment and these domains, we found that 145 patients, so 53% was frail and the rest was non-frail. And then, as I said before, we wanted to investigate the correlation between our frailty index and the frailty index of the comprehensive geriatric assessment. And we found that these two indexes were strongly correlated. So we were happy about that. That means that our frailty index is kind of the same as the much more commonly used frailty index. And then the first outcomes. Well, in frail patients, we found high rates of severe toxicity. 64% of frail patients had at least one grade 3 to 5 toxicity. And we also found that frail patients, half of them had a dose reduction, half of them discontinued chemotherapy early, and 60% was unplanned hospitalized in the first year at least once. And then in non-frail patients, these rates were maybe a bit better. Half of them developed severe chemotherapy toxicity. Also in non-frail patients, we found that 40% approximately was unplanned hospitalized in the first year. And then what about the quality of life and physical functioning at 6 and 12 months? Well, here you can see that composite endpoint I was telling you about. So the green bars represent the patients who were alive at 6 months with the same quality of life and physical functioning as they had before they started chemotherapy. The blue bars represent the patients who were alive at 6 and 12 months, but had a clinically relevant decline in either quality of life or physical functioning, or both. And the red bars represent the patients who died. So as you can see here, in patients with 2, 3, or 4 geriatric impaired domains, which were the frail patients, only 20% was alive at 6 and 12 months with the same quality of life and physical functioning as baseline, which means that approximately 75% of these patients either had a relevant decline in quality of life and physical functioning, or they died. And then a small sidestep, but I thought it was interesting. First, we thought, well, maybe in frail patients, it's because all of them are treated with a palliative intent, and then they have a really high risk of having poor outcomes. But therefore, we stratified results in frail patients based on treatment intent, and we found that even in frail patients who were treated with curative intent, only 25% had good outcomes at 6 and 12 months, and the rest of them had either decline in quality of life or died. And I think in frail patients treated with palliative intent, these rates are really, really bad. And then to answer our primary research question, what is the association between severe chemotherapy-related toxicity and long-term outcomes, which are decline in quality of life or physical functioning and mortality? And this is the graph of patients with frailty. And as you can already see, these are the patients who had severe toxicity, and these are the patients who did not have severe toxicity. And this composite endpoints differs. So patients who were frail and developed chemotherapy-related toxicity had a higher risk of these poor outcomes at 6 months. And this was what we also found in the multivariable logistic regression. We found a significant association between toxicity and a decline in mortality at 6 months. And in this multivariable logistic regression, we corrected for all the confounders. And then at 12 months, we found that in patients with frailty who developed severe toxicity, they especially had a higher risk of mortality at 12 months. And this, again, was also significant in the multivariable logistic regression when we investigated toxicity associated with mortality alone. And then in non-frail patients, you can already see that the composite endpoints for those who developed toxicity and those who did not have toxicity are kind of similar. And this was also found in the logistic regressions. We did not find an association between chemotherapy-related toxicity and these long-term outcomes at 6 and 12 months in non-frail patients. So what could be an explanation in these frail patients? Well, first of all, the chemotherapy-related toxicity, or for example, toxicity-related hospitalizations could have led to a decline or even mortality. Or due to these toxicities, patients stop their first-line chemotherapy and don't want or maybe don't dare to start a new treatment line because of these toxicities. So they discontinue treatment and the cancer progresses, and then the patients have a decline or mortality due to the cancer itself. Or the frailest patients at baseline have the highest risk of developing toxicity, but also the highest risk of a decline in mortality, irrespective of their cancer. So to conclude, we found in frail patients high rates of severe chemotherapy-related toxicity. And also in frail patients, we found that only 20% was alive with the same quality of life and physical functioning at 6 and 12 months. And I think especially in the palliative setting, an important treatment goal is to maintain quality of life. And I think these results show that treatment goals are often not met. And then in frail patients, we found that severe chemotherapy-related toxicity gives an extra risk of a decline in mortality. And then in patients without frailty, we found that toxicity does not extra increase the risk of having a decline or mortality. So I'll first talk about the strengths and limitations. And I think as a strength, this is the first study investigating the association between severe toxicity and the quality of life and physical functioning in older adults. And then because the study design of our 10th study, that's designed to also include frail patients, I think we managed to include both non-frail patients, but also a large group of frail patients. And we often learn in studies that it's difficult to include frail patients. So therefore, I think these results are important because this is the group of patients we are treating in daily oncology practice. So I think the results are representative of daily practice. And then I think important limitations are that we found that even in non-frail patients, half of them had an impaired geriatric age score, which might suggest that even the non-frail patients were relatively frail. And then we included the heterogeneous population with multiple tumor types who were treated with different types of chemotherapy. And this is what I found difficult to convince Dutch oncologists about my results, because the Dutch oncologists will say, yeah, oh, but this is a lot of tumor types, and I think these results won't count for the tumor type I am treating. I think this is not true. I think if we will find this in all types of tumor types, these poor outcomes. But we're trying to convince these oncologists, and therefore we are currently setting up the same study with the same endpoint, but then only focusing on older adults with metastatic colorectal cancer. So further convince oncologists about these results. And then maybe a more technical one, but we know that the odds ratio can be overestimated when the incidence of the outcome, which is in our case the decline in quality of life or mortality, is high. So it should be interpreted with caution. And I think these results show that we really need solutions to improve treatment outcomes of chemotherapy outcomes in older adults. And there are more solutions. I'll tell you something about two studies I really like. And I think the most important solution is, and I'm definitely not the first one who shows it, but I think we again show the importance of a pre-treatment geriatric assessment to identify frail patients. And based on this geriatric assessment, we can also start interventions. And I'll tell you something about the study later. And then I think it also shows that especially in frail patients, we have to reduce risk of chemotherapy-related toxicity. And one option to do this is to perform upfront dose reduction chemotherapy. And then another option is trying to detect chemotherapy-related toxicity in an early phase, but it may be still a grade 1 or grade 2 toxicity. There are many solutions that can lead to early detection. And one of them is, for example, using digital health, such as wearable technology or e-health. And I think my group in Mexico is much further with these digital health solutions than my group in Leiden. I think this is also a really cool solution. So first, a study about this geriatric assessment. Maybe you're familiar with it, but a geriatric assessment does not only help us identify frail patients, but it can also reduce treatment-related toxicity. So these are results from the GAP70 cluster randomized trial from the States. And what they did is that they included older adults with advanced cancer, and they included 718 patients who were starting a new treatment. And they randomized these patients between a geriatric assessment and usual care without geriatric assessment. And what they found, and what you can also see in this graph, is that the patients who had a geriatric assessment had less side effects, less toxicity. And I think one of the reasons could be that in patients who we are doing a geriatric assessment in, that can often lead to, for example, giving less intensive treatment or giving an upfront dose reduction, which can lead to lower toxicity. And they also found that patients who received the geriatric assessment had less falls, which is also an important outcome in older adults. And then back to the solution about upfront dose reduction. I think a lot of older adults are currently being overtreated because we are still giving a medicine that are tested in younger and much fitter patients who can endure a much higher dosage. And maybe a lot of older adults cannot endure the same dosage. So maybe we should perform upfront dose reduction of chemotherapy. And this is what the GO2 phase 3 randomized clinical trial did, a study from the UK. They included older adults with advanced upper GI tumors, and they included 514 older adults. And they randomized these patients between 100%, 80%, or 60% of the chemotherapy dosage. And what they found is that you can see in the graph that the patients who received 80% or 60% had much less toxicity, and they were able to complete more treatment cycles. And they also found that in these three groups, survival was similar. And maybe that's because when you receive 60% of the dosage, you can receive more treatment cycles, which leads to a similar survival. So inspired on the GO2 trial I just showed you, we are currently setting up the dosage study in the Netherlands. And this will also be a phase 3 randomized clinical trial, but a non-inferiority trial. And we will include older adults with metastatic colorectal cancer. And what we will do is also randomize these patients between dose-reduced chemotherapy or the standard dosage of chemo. And in metastatic colorectal cancer, you can treat patients with either monochemotherapy or combination therapy, and that could be a doublet or triple therapy. And there are not really data on how to choose if you should give an older adult monochemotherapy or polychemotherapy. And we will do this based on the geriatric age. So patients who have an impaired geriatric age will receive mono chemotherapy, and patients who have a normal geriatric age will receive a combination therapy. And I think these kind of studies, it's difficult to find funding in the pharmaceutical industry. So we were very happy that the Dutch Cancer Society wants to fund our study. And 40 Dutch hospitals will participate in the study, which I think shows the importance of this topic and that we need to improve treatment outcomes for older adults. And so I hope that dose-reduced chemotherapy will lead to less toxicity, a better quality of life, with again a similar survival. And when I think if the results of our study are positive, we will try to implement dose-reduced chemotherapy in Dutch guidelines. So again, this is the study design. So we will first do a G8 by these patients, and based on the G8, they will receive monochemotherapy or polychemotherapy, and then we will randomize them between the standard dosage of chemotherapy, an upfront reduction of 75%. So I've shown you some solution. I think these solutions can really improve treatment outcomes. But I also think, and I think this is a difficult opinion, but there are some patients who truly do not benefit from chemotherapy. And for example, I was surprised to find that in our study, there were patients with 4 out of 4 impaired geriatric domains, and we are still treating them with chemotherapy. And I think in these group of patients, there must be patients who truly do not benefit from chemotherapy. And I think it's important also for our global healthcare staff that we have shortages of global healthcare staff. We deal with increasing healthcare costs. We have to define patients who truly do not benefit from chemotherapy. So muchas gracias a mi equipo en Leiden, pero también en Mexico. And I'm really curious about your thoughts. Thank you very much.
Thank you, Georgia. Thank you very much for your presentation. Congratulations on this new trial. Thank you for giving us not only the insights about what you did, but what you're planning to do. Definitely, I think that those upcoming results of that new trial will most likely change like the oncology scenario and will make a lot of more questions. But I want to hear Laura, because well, she's our co-host. I'm sure she has a lot to say about what you just exposed. So go ahead, Laura, please let us know what are your thoughts on it.
Sure, great. Well, first, a big congratulations for your work. It's really commendable, and I hope that this will be, somewhat of a dialogue and a conversation to sort of better understand the work. And I think one of the beautiful things of this opportunity is to also sort of get a sense of what's happening in each of these where we all are working, because I undoubtedly there are differences. So I wondered if I could ask if you, when thinking about frailty, and you highlighted this particularly at the end, how, there's a small percentage of patients who had 4 out of 4 of the domains, which I think is a clear group to really consider not only the benefit, whether there's benefit, but actually really the harms of chemotherapy. So not only are we not helping the patients in terms of their quality of life or function, but really likely we're probably harming them by giving them a chemotherapy. And I think one of our sort of palliative care hallmark trials was, done by Jennifer Temmel, looking at patients with advanced lung cancer who got concurrent palliative care. And, many people would argue that there was a survival benefit among patients who received concurrent palliative care along with standard oncologic care, that in many respects, in addition to the facility, helping patients and families cope, but the survival benefit was likely that having palliative care involved actually helped facilitate those conversations of discontinuing chemotherapy at the end of life to prevent that harm. So I wonder what, I think, I imagine it's very different. There's certainly in the States, there's increasing initiatives to really look at particularly chemotherapy in the last 30 days of life is considered a very poor quality metric, and it's being increasingly tracked. I wonder just how is that being handled in the Netherlands, or I don't know, in Mexico, or how is that as a quality of care measure?
Well, I know that in Mexico, there are not many palliative care units or palliative care doctors. So I think in Mexico, that's also difficult point. And in the Netherlands, I think we have a lot of palliative care and a lot of hospices where patients go to die. But still, I think what my results also show is that oncologists are really optimistic and think, oh, I can still treat these patients. So still here in the Netherlands, I think a lot of patients die when they're still using chemotherapy. So,
but I think that was another striking thing that I know, the concordance between palliative intent chemo and frailty is pretty striking. And I wondered, did the oncologist have access to the measures that you were doing in terms of the frailty assessments at the time of treatment decisions?
Yeah, they had. I think 80% of the doctors could assess the geriatric assessment, and it depends on some hospitals. In some hospitals, the geriatrician and the oncologist made the decision to start treatment based on the geriatric assessment, but there were also hospitals in which the geriatric assessment was done after they started treatment. So that depends, but I think it shows that oncologists are really optimistic about their intent. Okay, we're going to start with a curative intent, and I think after a few months, they realize that it's still going to be a palliative intent. I think it's the optimistic glasses oncologists wear.
So but the palliative intent or curative intent binary was at the time of at baseline, right? That was
at baseline. Yeah.
I mean, because it was striking to me that I'm just going to look at that. 37% of the frailty patients were having palliative intent treatment, which suggests that, as compared to 21% of the non-frail group, right, which suggests that the clinicians had some awareness of their frailty in making that determination. whether conscious or not. And furthermore, another quarter, and perhaps you would say only a quarter of the frail patients had a dose reduction at front, and perhaps that number should be quite higher.
Yeah.
But noting that the palliative intent and dose reduction were suggest that, while optimistic, there was some awareness of the frailty of the patient. So I was curious, how much the awareness. So yeah.
Yeah, I'm not sure how it is in your institution, but I think not all oncologists are also like know how to read such a geriatric assessment. How do you experience that? Like, do oncologists get the recommendations you give, or do they understand the geriatric assessment and the interpretation?
Yeah, that's a great question. I mean, I think a lot of the treatment decisions are still really based on, in our group, on the ECOG scores. Which is used in, I don't know how broadly it's used outside of the US, but it's basically a 5-point score to assess the level of functional impairment. And it's not considering, all the other domains that are in your frailty assessment. It's really a functional status assessment, which, many is obviously a very key marker. And so that I would say is the key driver of whether patients are getting dose reductions or being offered chemotherapy. But I think that because now there's an increasing awareness of frankly oncologists being dinged for giving chemotherapy in the last 30 days of life, that is a poor metric of quality of care, that has actually helped change behavior.
One question.
Yeah.
Sorry. I just wanted to pick on something that you said, Laura, but if you want, go ahead.
Please.
Okay. Just like a brief note, in Colombia, we use also ECOG. It's like, let's say, the gold standard to decide if a patient should or should not receive chemotherapy. But that was a question that I also wanted to ask Joja, because we understand that maybe at the end of life, it's clear that we shouldn't, right? But what we see, and the population that she had on her study, were patients with a curative intent that were ECOG 1, and the new variable that we had to have in consideration, and that she found that is maybe more important than the other two, is that these patients were frail. And although they had an ECOG of 1, or even though they had a curative intent, they still present these bad outcomes when they were frail, right? So even if, and that was what the question that I wanted to ask you, Joja. I think that it's very difficult to set up an agreement with an oncologist, and I understand that, because maybe they think that frailty is because of the oncological disease, and they cannot wait to treat that frailty, maybe with nutritional, maybe with, let's say, other sources, to wait and see if that improves, to give treatment afterwards, right? They do not have that time. They have to begin right away. But how do you navigate, like, or convey in those type of situations, so they, for example, give a dose reduction? That was what you end up your discussion, and also mentioned throughout your presentation. We have the Nordic 9. You mentioned the GO2 trial. Both of them have shown that these type of patients from the start should benefit, right, on quality and physical functioning if we begin with a dose reduction treatment. But how do you convince the oncology team to do that? I think that, and I also want to make that question to Laura, because I do not know if, Mount Sinai, without a doubt, is one of the standards of healthcare in the US and maybe globally, without a doubt. How do you navigate those type of situations? Give me a minute, Dr. Andrea. I think that you have your mic on. Okay.
Well, I'll go first. I'm not an oncologist yet, or a geriatrician, so I don't have that much clinical practice. But for me, we're trying to do it with this study. Like, we can give them data. Like, look, survival is similar, but I don't have that much experience in clinical practice. So maybe, Laura, you know better answer.
Yeah, I don't, to be candid, I don't have the numbers of dose reduction, what the protocol adherence is to and dose reduction is for the different subcancer types. I certainly know that it's happening all the time and patients are starting out with a dose reduction, but I would say that similar probably to the data you're presenting, it's more likely to have a dose reduction once they're seeing toxicity from the treatment than it is to sort of start out empirically with a dose reduction.
That is way too late. That is like the difficult part. Yeah. And another thing is we're also using the kind of ECOG, it's called the WHO performance status.
Mm-hmm.
But what we always feel in Leiden is that, well, that for physicians or oncologists, it's kind of difficult to assess the performance status because there are studies that you can find that performance status is not that related to frailty. So assessing frailty by your clinical experience is, I think it's difficult, and therefore we need these geriatric assessments and these questionnaires to define frailty, because just looking at our eye, and I think that's really difficult for us as physicians.
Absolutely. I was wondering if you guys considered using, or in your future work, a frailty scale that was not a binary, but considered sort of levels of frailty. Because I think one thing that's striking is we're talking about a population that's able to show up right to their oncologist practice. They're ambulatory. They already like have as you said just now, a pretty high performance status to be considered for any of these treatments, right? I mean, if you look at the ADLs, there was, I don't know, one patient I think who had an ADL impairment. The other functional status impairments were IADLs. But so the function is not obviously really what we're able to discern on. And I wondered if you considered, something like the clinical frailty scale where you see, different levels of frailty.
Yeah, I think that's a really good question. My group chose to always use this frailty definition, but I think it would be easier for us, but also for reviewers, because we always receive the same feedback from reviewers that they want us to use, for example, a clinical frailty scale. So I think it would be easier if we have used that frailty scale, and then we also have a pre-frail group. But yeah. My group has made this decision, so I think we're going to keep to this frailty definition. But it's a really good question.
Well, I wonder just, especially for when you're talking about how to sort of navigate clinicians, right? And if an oncologist saw the difference between, a more severe level of frailty compared to sort of mild frailty, and then also for intervention targeting of populations, of how to sort of, as you said, pre-fail groups, right, who are at high risk, and what interventions you might target as opposed to those who are already displaying frailty.
Yeah, I think it's a good question. I'm not sure about it, but yeah, really good point.
I mean, I guess the question is like, if you look at within your if there's, I don't know enough about the distribution of your 4 domains. I know you said that there's a group that was 4 out of 4, but if somehow, if you did some, I don't know, like a latent class analysis almost of your different domains and sort of looking at stratifying either by frailty or not frailty, and sort of then seeing maybe there's a subpopulation sort of within it, might be interesting to do.
I think that the frailty index we validated our results with has a pre-frail index. So it would be interesting to look at what kind of patients these pre-frail patients are. Yeah, definitely.
Yeah.
There's also a question that I had regarding that definition of frailty. And it's because the article doesn't mention pre-frail, right? Pre-frail patients. We could consider that maybe a patient that has one alteration in one domain would be that type of patient, right?
Yeah.
And also, it's interesting because we also know that it's not the same a patient that maybe is pre-frail because has a neuropsychiatric condition, maybe, let's say dementia, that a patient that has an alteration on the social domain, right? That also has a different prognostic and a different course of the disease. What would you think? I know that this is not the scope of your article, right? But just like for the sake of the conversation, do you think that maybe we could find similar results on pre-frail patients, and we could also, let's say, say that they would have these alterations that you find on functioning, on physical functioning and quality of life, Jojo?
Yeah, I think that what you said, maybe the patients with only one impaired domain could be considered pre-frail. I think their outcomes must be somewhere between the frail and non-frail patients. I think so. Because what kind of frailty, how do you define frailty in your institutions?
We had a discussion on one of the previous sessions that we did regarding that. We use the Frey model, right? And also the deficit model. That's the models that we use mainly. But in non-oncological patients, we use G8, but that's not like just to screen patients. But when it comes to, for example, precisely define frailty in cancer, we do not have like a model, a determined model that we go to. And it's also interesting because we know that frailty is a syndrome that is related to age related, right? But in oncology, we could talk maybe about frailty in more in younger patients because of how the disease progresses and like presents itself. But well, that is, I do not want to go further on because I think that maybe um we'll enter in other domains, and the idea is to focus on your article. There are two questions, one on the chat that I'm about to read. But first of all, I also want to acknowledge that you use telephone calls um, to sorry to talk to the patients that were considered non-frail, right? And I would like to know if you think that it's possible also to do the geriatric assessment through telephone calls on the patients that are frail, because with the patients that are in rural areas, the people that are in distant places, I think that they may benefit from this. But I wanted to know what would be your take on it.
Well, I think in our group, we definitely believe that is also possible in frail patients. So for example, the study we are setting up, the dosage study, we'll also do a geriatric assessment, but these will be non-frail and frail patients. And we're going to do a baseline geriatric assessment by telephone by all patients. So even frail patients, we'll be calling them by telephone. So I think it's possible. Maybe you'll miss the frailest frail because they don't answer their phone, but maybe those patients wouldn't also go to the hospital to do geriatric assessment. So I think it's possible. I'm very curious about what is your view?
My experience is that we basically need this type of model because being in a low middle income country, there are many places that there's no other possibility. So, but we need the evidence, right, to be able to implement this type of models, because we cannot do it just because the need, but also we have to be certain that it works. So, for example, those kind of trials, I think that are going to be a landmark to implement those types of tools. The question that we have on the chat is the following. Let me read it to you. Thank you, Dr. Baltusen, for your excellent presentation and for allowing us to participate. I would like to make a common question. Taking into account that these patients, older patients, can experience grade 3 and 5 toxicity, and this include a stay in the ICU. The ICU also impacts the survival of these patients, generally due to the post-ICU syndrome. In this sense, could the results of mortality or increased disease burden be also exacerbated by the impact of the ICU stay? And finally, I would like to know if the geriatric 5M approach is applied to the choice of target oncological therapy. Thank you very much.
Well, thank you for these questions. I think regarding the first, I don't have any, we do have the data on ICU stays, but I didn't take it into account in these results. I think it's definitely possible the ICU syndrome is also a part of these results, but I don't know. But I do know that, for example, in the Netherlands, we're kind of strict on which patients can go to the ICU. I think the percentage of patients who had to go to the ICU is relatively low because we're really strict, much more strict than other countries in Europe.
And the United States.
And yeah. I don't know how it's in the States, but for example, during the COVID pandemic in Italy, everyone could go to the ICU, and in the Netherlands, we had to be really, really, really strict. So that's depending on the healthcare system, I think.
Yeah.
The other question that I have here is that, well, there's a brief comment. Let me do it first, and then I'll give you the question right away. Dr. Andrea Hernandez from the Department of Geriatric from Fundación Cardio Infantil, who said, help us to set up this meeting, said that in the group of the geriatric department, they, through COVID, they implemented the phone calls to do the geriatric assessment, and they she assured us that it is possible, but well, it was like a process, right? A curve of learning. The other question that I had, and this is for Laura as well, is now that we have understand that chemotherapy-related effects have this kind of impact, right? And maybe not only when it's level 3 or 5, but also 1 or 2. Do oncologists tend to consult either geriatric or palliative care in your institutions when this type of events happen, or how is this like some kind of bell ringing that helps you like accompany this type of patients, or how does this work on your institutions?
Josie, do you
Yeah, you go first, or
okay, I'm happy to, whichever. I think for us, we are very embedded in the oncology practices and palliative care. It happens that many of our palliative care providers are also geriatricians. And I, who am not a geriatrician, you joke, if you've been in the department long enough, you get sort of an honorary geriatrics card. But so all joking aside, we're very embedded such that the patients can get quickly seen by palliative care. So, the patients who are having toxicity are obviously having symptoms. And so they're much more likely to get referred to our embedded palliative care clinicians. But I will say that there is no standard frailty assessment, and there's certainly not a standard geriatric assessment. There's no among oncology. We have increasingly teams that, this is veering outside of oncology, but have co-management teams. And there's increasing literature on co-management teams in trauma or orthopedic surgery patients. And so that's sort of a growing space where we have more standardized assessments for patients, but it's not the standard by any stretch among oncology patients.
And I think in our institution, when a patient has severe toxicity in older adult, it is possible to consult a geriatrician. I think it's a different trajectory than the palliative care setting in the Netherlands. But then the geriatricians are not really happy with the oncologist, because they'll tell you, you should have consulted me before. That's where they want to have impact on the baseline. So it is possible, but they prefer to be involved much more before you start treatment, in the decision to start treatment.
Well, and I think that's what's sort of so striking about this study you presented, and then there was another one that was published in JAMA Oncology of another geriatric assessment sort of driven intervention, which just by virtue of having a population was getting usual care versus intervention of a geriatric assessment, that alone reduced the toxicity effects. And so, which obviously, if you're doing an assessment, you're then going to act on the findings you have. But that those patients who just had the geriatric assessment driven intervention fared much better among older adults with cancer, I think is very promising.
Yeah, and there's also another study from Canada who did the same. And they did a geriatric assessment after the treatment decision, and they did not find any improvement in side effects. So I think that shows that the window of this geriatric assessment really is like before treatment initiation.
For me, is really surprising what you are sharing, because I would have thought, or I would have expected, that is something that maybe in your institutions is something that is like a common thing, a usual thing. And it's striking that I think that we have realized in 3 different countries, maybe 4, taking the experience of Georgia, that is something that is quite a game changer, right? Something that is still being implemented, something that it's just being talked. And it's amazing to, precisely as a hot topic, had the opportunity to talk today about it and look for it. And thank you very much, Jojan, not only because of sharing it with us, but for all the work that you're doing. I'm sure that with all the peoples for all the people. I will leave the last word, so we can end as promised, to Laura. Laura, what are your takeaways? Your, like, the big conclusion that you would do for this session.
I think that so overall, a big congratulations to your work. I think it's clear that this, the upstream evaluation of patients is really a critical time point, that sort of thinking about patients and their unmet needs through a geriatric assessment or frailty assessment, however, whatever tool you're using, has a tremendous impact then on the downstream effects of both really, what I advocate for strongly is, tailoring the care that they're getting based on sort of their needs. And so, however, that is sort of the hallmark of palliative care for sure. And I think that this, by identifying these patients through whatever tool, is accessible in your institution is really an opportunity to really shine a spotlight on these impairments. And, hopefully by shining a light on the impairments of the patients, that will be, could be more compelling to the oncologists. But I do believe while they may be optimistic, certainly the hope is to not do harm. And so I think by sort of bringing it back to the patient and their unmet needs really will hopefully drive care. And I think you're on the start of an exciting path that we look forward to seeing frailty assessments or geriatric assessments being integrated into ASCO guidelines by the next 5-10 years of your work would be a really exciting contribution. And I wish you the best of luck with convincing oncologists near and afar of the importance of this.
Thank you so much. That's a beautiful conclusion.
Well, thank you everybody for being here, for sharing. Joja, again, I just want to add myself to what Laura said. We'll be looking out for everything that you continue publishing. Have a nice day. Laura, thank you very much. We'll stay in contact for further occasions. It was also a pleasure to hearing you and having you as a co-host. Have a good night. And well, that's it. Bye-bye. Take care.
Thank you,
Take care.
Juan.
Thank you so much, Juan.
Thank you so much for hosting and inviting me.
Have a great one. Bye-bye.
Thank you, Laura. Bye-bye.
Bye-bye.